Kindly unmute PPCLR1.
Okay.
Your time starts now.
Very good evening, respected judges. Here I'm presenting our case report titled Alveolar Ridge Split and Expansion Technique with Simultaneous Implant Placement in Horizontally Atrophic Mandibular Ridge. Managing horizontal bone deficiency in mandibular posterior region always remains a major challenge. Successful implant placement requires adequate bone width, necessitating augmentation of narrow ridges. Ridge split bone expansion technique is one such technique to augment the alveolar bone, which utilizes the viscoelastic characteristics of the cancellous bone, thereby creating sufficient space for simultaneous implant placement. This subsequently reduces the overall treatment time as well as the post-operative comorbidities. Here I'm presenting two case reports wherein which the horizontal ridge deficiency in mandibular posterior region was managed with ridge split expansion technique with simultaneous implant placement. A 50-year-old male patient presented with a desire to replace missing teeth in lower left back region with implants. And coming to the patient's dental history, he had undergone extraction of 36, 37, 38 due to mobility 10 years back. He had also undergone implants in other quadrants. Now, on clinical examination, it was found that the bone width at the crest was 3 mm in relation to 3.6 and 4 mm in relation to 3.7. And 2 mm below the crest, it was 5 mm in relation to 3.6 and 3.7. These are his CBCT findings. The CBCT report shows that there was adequate bone height, that is 12.8 mm in relation to 3.6 and 9.5 mm in relation to 3.7. However, the bone crestal width was 2.7 mm in relation to 3.6 and 3.1 in relation to 3.7. So according to Les Tolstonow classification 2014, the CBCT indicates that this is a case of severe ridge deficiency. So we plan to do alveolar split osteotomy expansion with simultaneous implant placement. This is a virtual implant simulation wherein which a 4.5 mm diameter implant was planned in both the sides. Now coming to the surgical technique, a paracrystal incision was placed. A full thickness mucoperiosteal flap was reflected. Osteotomy drilling was done in both the implant side, that is 3.6 and 3.7 region, up to 3 mm in relation to 3.6 and 4 mm in relation to 3.7. After the osteotomy preparation, horizontal crestal ridge split was done using the saw disc 1 from the Split Master 2 kit and connecting the two osteotomy sites. Later, a stress relief vertical cut was given 3 mm mesial and distal to the osteotomy site. And the ridge was expanded using chisel and spreaders, and then simultaneously implant was placed. Implant size of 3.3 mm and 4.25 mm was placed. Suturing was done. This is the radiograph after implant placement. The post-operative findings in pre-operative, the bone width was 5 mm. It increased to 9 mm in immediate post-operative, and 3 months post-operative, it was 7 mm in relation to 3.6 region. In 3.7 region, the bone width was 5 mm pre-operatively. Immediate post-operatively, we achieved 10 mm and it was reduced to 8 mm 3 months post-operative. This is the CBCT section post-operative at 3 months. There was adequate amount of bone, both buccally and lingually, in relation to 3.6 and 3.7. Now, coming to the case report 2, a 42-year-old male patient again reported with the same chief complaint to replace the missing teeth in lower posterior. His past dental history reveals that he had undergone extraction in relation to 3.6 and 3.7 8 months back due to severe periodontitis. And during that appointment, we had preserved the socket using xenograft and suturing was done. 8 months after he came back, and when we did a clinical examination, there was a horizontal ridge deficiency. So we took a CBCT. These were the CBCT findings. The CBCT report showed that there was adequate amount of bone height, that is 11.1 mm in relation to 3.6 and 10.9 mm in relation to 3.7. The crestal bone width was 6.5 mm in relation to 3.6 and 2.3 mm in relation to 3.7. So the diagnosis was it was a localized horizontal alveolar ridge atrophy ranging from mild to severe ridge deficiency. So the treatment options were either GBR or block bone autograft. We opted for or alveolar split osteotomy. Since GBR and block bone autograft was it takes more treatment time and second stage surgery, we opted for alveolar split osteotomy expansion with bone grafting and implant placement. Again, the surgical technique, we placed a paracrystal incision, full thickness mucoperiostal flap was reflected. Osteotomy sites were prepared up to 3 mm size diameter. And then using the sawdust from the split master toolkit, we made a horizontal ridge split. Later, vertical ridge split was done, 3 mm mesial and distal to the osteotomy site. And the ridge was expanded using spreaders and implant was placed of 3.75 mm diameter. There was jumping spaces 2 mm greater. So we placed xenograft and then the wound was closed. And post-operatively, preoperatively, the bone width was 5 mm. So post-operatively, it was 9 mm, gradually reduced to 6 mm. 3 months post-operative in relation to 3.6. In relation to 3.7, preoperatively it was 5 mm. Then post-operatively it was 10 mm. 3 months post-operative, it was 7 mm. The CBCT section shows that is there is adequate amount of bone ranging from 1.1 mm both buccal and lingual in relation to 3.6 and 1.1 and 1.6 mm relation to buccal and lingual side of 3.7. Coming to the conclusion, alveolar split osteotomy, it is a highly predictable, minimally invasive technique for horizontal ridge augmentation in mandible. Simultaneous implant placement acts as a mechanical scaffold to maintain the gap. It reduces the overall treatment time and eliminate the need for secondary donor site and preserve the thin cortical boundaries. Proper case selection and meticulous surgical techniques are the key to successful ridge split. These are my references. Thank you, sir.
Okay. This is a case of full mouth rehabilitation by using bicortical implants. Okay. See, this is the usual scenario we are facing every day-to-day life in our dental clinics. The patients who are ideal candidates for treatment offer lack of financial willings to proceed. Patient who poses the financial willings to undergo the treatments often present with severely compromised oral foundations. So this is the situation that we are facing day-to-day life. So this patient came to me, a 66-year-old man came to me. He wants to fix teeth. That is within 10 days. His deadline is 2 weeks. He wants to take photographs with his daughter on his daughter's wedding day with fixed teeth. He's demanding for that. So I asked him to take the OPG. See this OPG, you can see the sinus floor. This is the sinus floor, you can see. This is almost pneumatized sinus floor. And you can see the mandible also. The IAN, you can track the IAN, okay? This is a severely compromised case, anatomically, biologically, and physiologically compromised situation. Why physiologically? See, his HbA1c, you can see it is 9.6. So conventional implant protocol is not possible in this case. Traditional two-stage implants requiring extraction, sinus slips, block, bone grafting, nerve lateralization, everything it is not possible. And 6 month day, patient won't allow 6 months. Systematic metabolic constraints further compromised typical cellular bone healing. Conventional osseointegration protocols present a very high risk of infection, impaired healing, early implant failures. Okay. So what I did, I explained to him about the strategic implant. Strategic implants are nothing but it's a one step forward implantology. That's 4D implantology. It is nothing. It is a merger of conventional implantology, prosthodontics, orthopedic traumatology, and time. That is because this era we are very much cautious about the time. Time is a very important factor. So he's ready to do ready to have strategic implants. So the first day, what I did, I extracted all mobile teeth, and I placed in the upper teeth. I placed 6 polished bicortical implants immediately placed, and engage the cortical load-bearing anatomical buttresses. I'll show the place where I placed. See, the anchorage sites, engagement to the premaxillary, pterygoid plates, nasal floor, and palatal buttresses. So why is it? It is the biological. Since the patient was diabetic, almost D3, D4 born, what I need is corticalization by these implants. Okay, then for the lower, I selected KOC, King of Implants. KOC is called the King of Implants. Why it is called King of Implants? It's a single piece implant. It's very much similar to the conventional torque implant, but the only difference is the collar region. See, I engaged the mandible. Mandible is a less vascularized cortical bone, engaged, and did it in a keyhole conservative surgery. Flapless keyhole techniques preserved the periosteal blood supply and natural biological width. Also, it reduces RAP, regional accelerative phenomenon. Cortical locking is less susceptible to systemic oxidation defects, making this protocol highly stable and medically compromised patients and smokers. This is what my procedure first day. A traumatic extraction, since it is mobile, even though did a traumatic extraction, placed the implants, polished implants, 6 upper, 6 lower. And the second day, did a metallic framework and wax vital relation. Then third day, the hybrid denture fabricated bars placed on the implants and minor adjustments was done, then cemented, and within the third day, I gave the processes to the patient, satisfying all his dream, all his demands. See, this is the first picture, and this is the final picture. That is within 3 days, I fabricated everything. See, this is a OPG after 11 months. See how the implants are integrated. And it is these type of implants are very suitable for diabetic smokers. And the third main factor is time. It can be given within a period of 3 days or 72 hours, not more than that.
So, good evening, everyone. My presentation is on enhancing osseointegration, the role of sticky bone in immediate implant placement, a case report. So, why immediate implant? What are the advantages of immediate implant? So, immediate implant gives us a clear biologic and aesthetic advantage. So, the first one is it preserves ridge architecture. That is, the natural process of bundle bone resorption that follows extraction is prevented, and it also shortens the treatment time, and immediate implant also supports the soft tissue profile and the interproximal papilla, leading to better aesthetics. However, the central and the enduring challenge with this technique is achieving predictable regeneration of the peri-implant hard and the soft tissue. So it is where this motivated us to use the sticky bone. So what are the clinical challenges of using an immediate implant? So the first one is the jumping distance. So if this is not adequately managed, it will fill with osseous fibrous tissue rather than bone. And second is buccal bone deficiency, which is common during traumatic tooth loss. And third is graft stability. That is, it must resist displacement and migration during the early healing process. So fourth, there should be rapid angiogenesis. Only if there is a blood supply, the graft will get adequately perfused and osteogenesis can proceed. So primary and secondary stability. Primary stability is mechanical engagement of the implant, whereas secondary stability is biologic. That is, it occurs after bone regeneration and remodeling. So during the transition phase, there will be a dip in the stability that occurs usually during the third or the fourth week. So sticky bone is relatively relevant to use at this point. That is, it supports a biologic healing. It will bridge the gap between the initial mechanical fixation and the long-term regenerative success upon which the secondary stability depends. So next is, why sticky bone? So sticky bone is nothing but you combine a particulate bone graft with IPRF, which acts as a fibrin binder. So this will result in a cohesive graft that can be molded and adapted directly to the defect. And second thing is, it also acts as a growth factor reservoir. So there will be a sustained release of growth factor, which promotes early angiogenesis, and the cohesive fibrin stabilized structure will provide space maintenance. So it will prevent collapse and preserves the volume required for new bone formation. So in short, sticky bone converts a passive particulate graft into an active regenerative scaffold. So moving on to the case report, here we are seeing about an immediate implant placed with sticky bone and a PRF membrane to achieve predictable peri-implant bone regeneration and successful osseointegration. So patient profile. So a 32-year-old female patient, she reported to the department with a history of mobility for the past 1 week. So on history taking, she revealed that she met with a road traffic accident 6 months before and she had not undergone any treatment. Now on clinical examination, the maxillary left central incisor was diagnosed as hopeless, demonstrating grade 3 mobility. The other clinical findings were a class 2 gingival recession, and there was radiographic evidence of bone loss. So we came up with a decision-making algorithm. Here, first, we say that is, there is a traumatically compromised tooth. So the first question is whether the tooth is salvageable. Here, the prognosis was hopeless, so we thought that extraction was indicated. The second question is whether the immediate implant placement is feasible. So in this case, adequate apical and the palatal bone was present. Third, whether primary stability could be achieved at placement, and the answer was yes. Fourth, we assessed whether a peri-implant defect or a buccal bone deficiency was present, and in this case, we had a buccal bone deficiency. Final, that is whether a peri-implant, so because of the presence of a buccal bone defect, we thought that we can use a combined protocol, that is immediate implant with sticky bone and a PRF membrane. So moving on to the surgical workflow. So here the first step was atraumatic extraction of the tooth 2-1. So here particular care was taken to preserve the buccal and the palatal socket was intact. The second step, a full thickness mucoperiosteal flap was elevated so that we can visibly see the buccal bone defect. And then the osteotomy site was prepared using sequential drill, and 5 into 10 mm neodent implant was placed to the position of 2-1, engaging the apical and the palatal bone to achieve primary stability. Then preparation of IPRF and the PRF membrane. So for both the preparation, 20 ml of blood was collected and 10 ml of blood was taken in a test tube, centrifuged at 700 RPM for 3 minutes to obtain IPRF. So you will have the formation of an yellow fluid, which was then mixed with the particulate bone graft to form sticky bone. The other 10 ml was then centrifuged at 3000 RPM for 12 minutes to form a PRF clot, which was then compressed into a membrane using a platelet box. Then the prepared PRF membrane was placed into the site to fill the jumping gap and also to completely cover the defect. Then the PRF membrane was placed over the bone graft. It was then sutured to achieve primary closure, and a periodontal dressing was given during the initial healing stages. So the patient reported after 9 months following uneventful healing. So here, a radiograph was taken to confirm osseointegration. Then an implant coping was placed to accurately record the fixture position. An impression was recorded to allow the laboratory fabrication of the definitive prosthesis, and shade matching was done. Then the next step was ZIG trial. Here the ZIG trial was prior to prosthesis delivery. We carried out a ZIG trial to verify the accuracy of the working cast. So the ZIG was tried intraorally to confirm the passive fit and complete seating. This was corrected, correlated radiographically, which confirmed complete seating.
Your time starts now.
Good evening, all. This case presented with three converging challenges: missing tooth, horizontal ridge deficiency, and high aesthetic demand. Let me start with asking a question: whether, can implants be placed in this site without augmentation? If done so, it will result in the compromised aesthetics and function. So this type of cases need horizontal ridge augmentation. Augmentation as a first line for achieving a proper contour and proper function and aesthetics. So let me walk you through the surgical and prosthetic approach for reconstruction of maxillary aesthetic zone with Cowrey's bone shell technique. So this case combined the horizontal ridge augmentation and staged implant placement, prosthetic finesse to obtain an aesthetic smile. To understand why, we have to look in residual ridge resorption. Within 1 year after extraction, there was 5 to 7 mm of buccal bone reduction and 2.5 to 4.5 mm of vertical reduction, of which 30% of reduction takes place within 3 months. So this reduction will result in the labial concavity, and which pose challenge in the implant placement and attaining a aesthetic outcome. Let me explain a gist on the treatment options and prosthetic options. Based on the available bone level, Mission Judy classified the treatment options and prosthetic options under 4 divisions. In my case falls under the augmentation criteria. Since we needed more than 2 mm of bone augmentation, we opted for the bone block grafts. So these are all the biomaterials used for augmentation. Compared to all other grafts, autogenous bone grafts are considered as gold standard because of its osteoinductive, conductive, and osteogenic potential. Rest all other grafts regenerates by means of osteoconductivity, and the only exception is the demineralized freeze-dried bone graft, which regenerates by means of osteoinductive potential. So these are all the augmentation techniques. And the reason why we didn't choose GBR is the mean, although the mean implant survival rate was found to be 100%, the complication rate compared to bone block graft was found to be higher. So coming to the case report, a 59-year-old male reported to OP with a chief complaint of missing tooth in the left upper jaw front tooth region for past 2 years and wanting replacement of the fixed type solution for the same. Coming to the intraoral examination, patient had a missing tooth in relation to 2.1 and 2.2. Supra-eruption was found to be 2 mm below the occlusal plane, and labioversion was evident. Patient had an increased overbite. Reverse curvature of lower incisor plane was found, and the lip line was found to be medium. Smile line was found to be low. Edentulous span width was 18 mm. Restorative space height in relation to 2.1 was related to 9 mm, and 2.2 was 11 mm. Buccolingual ridge defect was found to be 3 mm, and apicocoronal ridge defect was found to be approximately 2 to 3 mm. Coming to blood investigations, all these values are found to be nominal. Radiographic investigation, the most significant part is the mid-level width was found to be 3 mm in 2.1 and 2.2. So even if we plan for 3.3 mm implant, it will result in the labial cortical plate perforation. And the most significant thing is we have to advise for a profile radiograph in mandible. This gives an idea of how much amount of bone is present in the mandible for safe bone graft harvesting, as well as it also gives an idea of the proximity of the root apices. So the treatment plan was Cowrey's bone shell technique followed by staged implant placement. Just on Cowrey's bone shell technique is it was introduced by Ford Cowrey, and the A corticocancerous bone graft was excavated from the donor site, and the cortical cortical shells are separated. These cortical cells are secured with the fixation screws onto the recipient area. The generated gap is filled with the particulate graft. So these are all the armamentarium. And coming to the procedure, under local anesthesia, vestibular incision was carried out, and from canine to canine region, a full thickness mucous.
Good evening, all. I'm presenting a case report on modified palatal roll flap technique for horizontal soft tissue implantation. Starting with a brief introduction on soft tissue implant health, recent emerging evidence suggests peri-implant soft tissues are helpful in maintaining peri-implant health. Vertical soft tissue deficiency at edongenous implant site can lead to a disarray of facial gingival margins and insufficient papillar height. Similarly, horizontal soft tissue deficiency, especially at the labial aspect of the implant, can lead to implant visibility through the overlying mucosa and an improper convergence profile. Importance of soft tissue augmentation. Systematic reviews in literature concludes that augmentation of attached mucosa leads to better peri-implant health, leading to long-term success of the implant therapy. Mucosal thickness using autogenous graft can reduce crystal wounds. Better soft tissue seal at implant collar facilitate for better oral hygiene. Soft tissue augmentation during second stage surgery. Modified palatal roll flap technique can be a significant addition to the second stage implant surgery in cases of implants placed at sites with least labial bond support. This technique depends on utilizing the gingival tissues over the implant cover screw and rolling it under the buccal mucosa in order to augment the soft tissue labeled to the implant. This is a case of a patient which I come across during my clinical practice. 18-year-old male patient reported with LA's class 3 fracture in relation to two. And we planned and placed an immediate implant for this patient. And after a 6-month review, it showed a bony defect around the implant, and we proceeded with bone augmentation. And the patient was recalled again after 6 months for second stage surgery. And peri-implant mucosal thickness was found to be 1 mm. So we planned and proceeded with a modified roll flap technique. Several studies were found in literature regarding the modified roll flap technique. Kulkarni et al., according to them, this procedure is of considerable value in the maxillary aesthetic region. And Barakat et al., they concluded this technique effectively augment the thickness of the labial peri-implant soft tissue. Now going to the case in detail. This is a preoperative photograph of the patient and the radiograph. The tooth was extracted atraumatically and the socket can be seen. And an immediate implant of size 4.25 into 15 mm was placed in the site. And the jumping distance was managed by placing the bone graft. And a palatal connective tissue graft was procured and placed above the bone graft as the barrier membrane. And the sutures was given. This is the immediate postoperative radiograph. And a temporary acrylic partial denture was given. Suture removal was done on the 10th day. Now the patient was recalled after 6 months, and on sounding, we found clear vertical bone loss was found in the labial region. So we planned to go with a bone augmentation using bone graft and collagen membrane, which is used as a barrier membrane. And this is a preoperative radiograph before graft placement and postoperative radiograph after placement. And the suture removal was done on the 13th day. And after this, the patient was recalled after 6 months for second stage surgery. And preoperative view was this. And we measured the peri-implant mucosal thickness, and it was found to be 1 mm. So we decided to go for a modified roll flap technique. These are the incisions. A horizontal incision was placed 2 to 3 mm palatal to the end of the cover screw, and it was a full thickness incision. Another 2 small vertical incisions were placed in mesial and distal to the screw border as wide as possible, and also by preserving the gap. And it was extended labially to include the keratinized mucosa. And the flap was then elevated from the underlying bone and screw, and gingiva over the screw, including the palatal extension, was precisely de-epithelialized. This is the technique of rolling the flap. The flap is carefully rolled, and it is sutured to its upper counterpart and also to the surrounding soft tissues. This is the suture. And now we measure the immediate post-operative peri-implant mucosal thickness, and it was found to be increased to 4 mm. This is the suture removal, which was done after 10 days. And now the patient was recalled after 2 months, and the prosthetic procedures was done. And the review, it is now showing is on the day of prosthesis placement. The prosthesis placed, and this is the immediate post-operative X-ray. Now we measured the peri-implant mucosal thickness, and it was found to be 1.5 mm. We have gained a little bit tissue in this region. Now we assess the modified bleeding index. Modified plaque index was measured. The score was found to be 0. Probing pocket depth was measured, and the score was found to be 1 mm. And the width of attached gingiva was measured by staining with Lugol's iodine solution, and it was found to be 6 mm. And the implant aesthetic score was found to be acceptable outcome. Now, this is the preoperative and postoperative photograph of the patient. Now, coming to discussion. Modified roll technique has been reported by several authors to have resulted in improved soft tissue profile. And this procedure needs a critical evaluation, and if found to be potentially helpful, should be made a part of routine second stage implant retrieval surgical procedure. These are my references. Thank you.
Yes. So thank you very much for giving me this opportunity to share and present my work with all of you. My topic for today's presentation is immediate implant placement. Its predictability in everyday practice. So the first question that comes to our mind is, why immediate implant? Why is it so better than any other method? So when we see, it helps us to maintain adequate bone quantity, and hence the aesthetics is also better. So the patient is also very comfortable because we can do the implant procedure on the same day of extraction. And so the time taken to complete the procedure is also getting reduced. So when and where can we place immediate implants? So the first thing is, whenever there is no active infection, it can be in the anterior or the posterior teeth, we can go ahead and do an immediate implant. We just need to have three things in mind. Can I do an atraumatic extraction without injuring the soft tissue and the buccal plate? And can I maintain an ideal implant position after extraction? And will I have adequate primary stability? If we are able to bring in all these things, then we are ready. So some of the challenges that we may face while doing the immediate implant is, first is the atraumatic extraction. Second is to get the three-dimensional position right. Third is to achieve primary stability. And last is to manage the soft tissue. So my presentation will deal about some ways which I follow in order to bring in all these four key elements. So for an atraumatic extraction, if it is a molar teeth, the first thing that we need to do is split the tooth buccolingually. So this is a patient where the root canal was re-root canal treatment was also done. Still, the patient continued to had some kind of an abscess. So an atraumatic extraction, the tooth was split into two, and with very minimal force, both the roots were extracted. And in this image, we can see the interdental bone, which is very well maintained. So the second key aspect is to get the three-dimensional position right. So whenever we do an immediate implant, this is a very, very big challenge that we face. Is by the time we place the implant, we finally see that the implant is into any one of the roots, and it is not exactly in the center or in the interdental septum where it needs to be. So one technique that we can follow is something called as the root guided osteotomy. So this is one in which the implant drilling is done even before extracting the roots, so that we get the accurate position in the interdental septum. So once the implant osteotomy is done, we can remove the roots and then place the implant. So this gives us an accurate position of the implant in the three-dimensional manner. So this is again a similar case in which a root-guided osteotomy was done, and we will be able to appreciate the exact position of the implant in the interdental septum. And this is the clinical image of those patients. So the third key aspect is to get the primary stability. So when we use our normal drills in order to do the osteotomy for a posterior immediate implant as well as for an anterior immediate implant,
we tend to cut the bone, which makes it more vulnerable to get a very less primary stability. Hence, when we use osteodensification burrs like Denza drills, we are condensing the bone onto the sides, and even very little bone that is available, we are able to use it in order to get the primary stability. And the fourth challenge is the soft tissue management. So especially for a posterior teeth, when we extract the teeth, we find that the extraction socket is very big. And if we want to suture it, we have to raise huge flaps in order to suture them. So instead of raising a flap, we can do a customized abutment where we can add some Teflon into the extraction sockets, which are sterile, and use composite to build over it. Then once we remove the customized healing abutment, we can polish it nicely and again put it back onto the socket. So this will help us to seal the socket perfectly. And this is the kind of result that we will get after 3 months when we remove the customized abutment. And this provides a wonderful bed of soft tissue cuff that is being formed. So these are few cases that I want to show in which these principles were followed. So this is a case of immediate implant in the aesthetic zone where there was a root stump which was already root canal treated. So an atraumatic extraction was done and the implant was placed. And on the day of implant placement, a healing abutment was given. So after 3 months, when we removed the healing abutment, we saw that we had a round soft tissue cuff that was formed. So till this stage, the patient was managed with a Maryland kind of a bridge. So then a customized provisional restoration was given. And after 3 weeks, we were able to find that we had a wonderful soft tissue profile that was created because of the provisional restoration. So these are the images of the patient after on the day of crown cementation, as well as 1 year later, 1 year follow-up. So similarly, an immediate implant in the mandibular molars, where the same root guided osteotomy was done and healing abutment was placed, and the final healing abutment was placed. And after 3 months, we were able to see nice soft tissue that was formed. But we wanted it to have a very good profile, and hence a customized healing abutment was given. And this was the gingival cuff that was formed after 2 weeks. So this is a 1 year follow-up of the same case. So I would like to conclude my presentation by saying that immediate implants can be very much predictable, and it can be predictable even for beginners. If we are able to take care of 4 key aspects of atraumatic extraction, getting the 3-dimensional position right, and having adequate primary stability, and when we are able to manage the soft tissue properly by providing a very good gingival cuff around it. So these are my references. Thank you.